Hello, this will be the second lecture of the breast pathology series. In this lecture, we will be discussing an introduction to breast cancer, its epidemiology and risk factors, as well as pathogenesis. Breast cancer is the most common non-cutaneous malignancy in women worldwide. It is the second most common cause of cancer-related death after lung cancer. The mortality rate of breast cancer has dropped since the 80s from 30% to less than 20%. And this is attributed largely to increase in the screening, where cancers are being detected early on, where treatment and cure are possible. And also the improvement of the outcome from the modern therapies. In the United States of America, the incidence is stabilizing, while it's increasing in other parts of the world. The lifetime risk of breast cancer in women is 1 in 8, meaning 1 in 8 women will possibly have breast cancer by the age of 90. The most common histologic subtype is adenocarcinoma, representing 95% of the cases. Other histologic subtypes include lymphoma, metastatic tumors, adenoid cystic carcinoma, squamous cell carcinoma, but you guys don't need to worry about these as these are very rare. There are 3 clinical subtypes based on the expression of mainly estrogen receptor and HER2, in addition to progesterone receptor. These 3 subtypes are ER positive, which is present in 50 to 65% of the cases. By definition, these are HER2 negative. The second subtype is HER2 positive, regardless of the ER status. These are present in 10 to 20% of the cases. And triple negative when ER, PR, and HER2 are negative. This is a table for comparison between the 3 clinical subtypes. Notice that in all ethnicities and races, ER positive, HER2 negative subtype is the most common. Typically, it has low-grade morphology. Notice also that regardless of the clinical subtype, bone is the most common site for metastasis. This graph plots the age at diagnosis with the breast cancer rate per 100,000 women. This also underscores the fact that estrogen receptor positive, HER2 negative clinical subtype is the most common subtype of all breast cancers. The previous clinical subtype being was based on immunohistochemical expression. A similar subclassification is based on gene expression profiling using genetic assays. Divides the breast cancer into 4 subtypes. Luminal A, in which ER is positive, HER2 is negative. Luminal B, in which both are positive. HER2 enriched, in which HER2 is overexpressed but ER is negative. And basal-like, in which everything is negative. There are multiple risk factors for breast cancer, the most important of which are age and gender. Breast cancer is really rare before the age of 30, although cases have been reported. 75% of breast cancers occur in women older than the age of 50, and only 5% in women younger than 40 years old. It's 100 times more common in women than in men. Family history is an important risk factor, and this risk is amplified if the affected relative is first degree, like a sister or a mother or a daughter, and if the patient was affected at a young age. The genetic predisposition or the familial predisposition likely represents a weak penetrating genes that increase the risk of breast cancer. Geographic factors also play a role in increasing the risk of breast cancer. The fact that breast cancer is really more common in the US and Europe than in Japan. Interestingly, when women move from Japan to the USA, even at an adult age, they acquire the high risk of the US. This could be explained by diet and breastfeeding habits. Also, regions of the world with increasing Western habits, such as fast food, obesity, low number of birth, decrease in the number of or the duration of breastfeeding, are showing an increased risk of breast cancer. Also, certain differences are seen between different ethnicities. As we mentioned earlier, uh, ER positive HER2 negative breast cancer is the most common subtype in all ethnicities. European women tend to have more frequent breast cancer than other ethnicities. However, when they acquire it, Hispanic and African women tend to have more aggressive tumors occurring at a younger age. Also, reproductive history has an impact on the risk of breast cancer. For example, nulliparity, meaning women who have never got pregnant, older age at first pregnancy, early menarche, meaning early age of having the first menstrual cycle, and absence of breastfeeding. All of these increase the risk of breast cancer. This is basically explained by a higher or longer exposure to estrogen, which, as we will see later, has an important role in promoting and developing breast cancer. Other risk factors include alcohol consumption and obesity, in addition to postmenopausal hormonal replacement therapy. The last two factors, obesity and hormonal replacement therapy, um, again underscore the importance of estrogen. Obese women have more estrogen than normal weight women, and hormonal therapy postmenopausally also contains estrogen. Again, estrogen plays an important role in promoting and developing breast cancer. The pathogenesis of breast cancer is an interaction of genetic, hormonal, and environmental factors. This is a schematic representation of the three different pathways for developing breast cancer. The uppermost one represents the ER positive HER2 negative cancers, which are the most common one. More likely, they represent a progression from a precancerous lesions such as flat epithelial atypia into atypical hyperplasias, ductal carcinoma in situ, and then into invasive malignancy. The low-grade atypical ductal hyperplasia and low-grade ductal carcinoma in situ are almost always ER positive. Important genes involved in this pathway include PIK3CA. The second pathway, which is ER and HER2 positive, also involved HER2 and TP53. Again, precancerous lesions include apocrine metaplasia, atypical apocrine adenosis, apocrine DCIS, and then invasive malignancy. The last one, which is the triple negative, meaning it's negative for ER, PR, and HER2, likely involve TP53, BRCA gene, and result in a triple negative or basal-like phenotype. The BRCA gene mutation could be germline, meaning they are inherited or occur at the level of the germ cells, affecting all cells of the body, or acquired, affecting only the tumor cells. In any case, they are involved in the triple negative breast cancer subtype. The genetic involvement in breast cancer can be familial or, with the exception of BRCA2, those other mutations can be seen in sporadic or acquired cases. For BRCA1, the type of mutation is different between sporadic and germline cases. In germline, it's typically either deletions, point mutations, etc. While in acquired cases, it's epigenetic change, meaning methylation of the gene without changing the sequence of it. And this results in activation of the gene. When the change occurs by methylation without affecting the gene sequence, that's called epigenetic mutation, and it is classic for acquired cases. Another important gene is the HER2 gene, which is a receptor tyrosine kinase. It promotes cell proliferation and inhibits apoptosis. It is vital for each breast cancer case to examine the presence or absence of HER2. In the past, HER2 positivity was associated with poor prognosis, but now, with the advent of targeted HER2 therapy, the survival has improved. The targeted therapy is a specific antibody that targets the HER2 tyrosine kinase, thus inhibiting its activity and resulting in increased response of the tumor to treatment. So in addition to genetic risk factors, hormonal risk factors are also important, and all of these revolve around the presence of unopposed estrogenic effect. As we mentioned in obesity, post-menopausal hormonal replacement, etc. Estrogen effect results in the production of several factors, including transforming growth factor, alpha, platelet-derived growth factor, and fibroblast growth factor. All of these promote the growth and proliferation of tumor cells. And the expression of ER should be examined in all breast cases, because if the patient is positive, then she can benefit from estrogen antagonists such as tamoxifen. Tamoxifen will result in decrease in the recurrence, decrease the stage, and improve the survival of patients with breast cancer who are ER positive. And finally, environmental factors related to diet, obesity, reproductive habits, and breastfeeding patterns. These were all discussed previously, and they have a significance in increasing the exposure of the breast tissue to estrogen, and also underscore the geographic differences between different countries. Thank you so much, and if you have any questions, please do not hesitate to ask. Thank you. Sporadic. Examples include BRCA, which is typically seen in triple-negative breast cancer. This can be familial or acquired. BRCA2 typically results in ER-positive cancers, and BRCA2 is really unlikely to be seen in sporadic cases. It's almost all the time seen in germline setting. Both of these genes are tumor suppressor genes involved in DNA repair. Being a tumor suppressor means that both locations of the gene should be mutated or inactivated for the tumor to develop. Very important gene is TP53, which is seen in many types of tumors, not only breast. It can be seen in brain cancer, osteosarcoma, etc. Another gene is P10, which is also involved in some subtypes of endometrial carcinoma and as part of Cowden syndrome.